Hi, I'm Dr. Dan Kelly, and this is a PNI Minute. Hi, I'm Dr. Daniel Kelly. I'm a neurosurgeon, and I'm the director and founder of Pacific Neuroscience Institute. The concept of keyhole surgery has been around for a while, but it's only in the last decade or so that it's able to be practiced on a regular basis. And it really comes down to a variety of key factors. First of all, the instrumentation that we use, including surgical navigation, the Doppler probe to localize blood vessels, and probably most importantly the endoscope, which is a surgical telescope and allows us to take the visualization tool into the area that we're operating on. These factors have really promoted the ability of keyhole approaches and their safety for our patients. So we have a variety of keyhole approaches. The most common that we use are the endonasal endoscopic approach, which is through the nose, the supraorbital eyebrow craniotomy, which is a little incision through the eyebrow, as well as the retromastoid approach, which is an approach behind the ear. One of our most innovative keyhole approaches is what we refer to as gravity-assisted, in which we position the patient in such a way that a tumor that is covered by what we would call eloquent cortex, an area that we don't want to damage, the tumor is at the surface of a midline dural membrane called the falx, and by putting the patient on their side, the side opposite the tumor down as shown in the illustration, it creates a space whereby we can bring the endoscope in and the microscope, and we can open this falx, this midline dural membrane, and access the tumor with minimal to no manipulation of the surrounding brain. This has been a very good approach for many patients with metastatic brain tumors. So by the name keyhole surgery, one envisions a very small opening, and in fact that's true. For the endonasal approach, we're using the natural corridors of the nostril, so there's no incisions on the face. For the eyebrow craniotomy, it's a very small incision which is really buried in the eyebrow and cosmetically has a very nice result. And for all of these other keyhole approaches, they're usually very small incisions, and we typically don't shave much hair, so that's another thing that patients like. But obviously the cosmetic appearance and outcome is really secondary to what's going on in the brain. We have to ensure that we get the most, if not all, the tumor out, and do so without causing collateral damage to critical blood vessels and surrounding nerves and the brain itself. The most common tumors that we use the keyhole approach on include pituitary adenomas, which are removed through the endonasal route, as well as a variety of meningiomas, which could be through the endonasal route, the supraorbital route, retromastoid or other approaches, as well as gliomas, including glioblastomas, and metastatic brain tumors. One of the main advantages of the keyhole approaches and concept is that our patients tend to recover very quickly. Some patients go home the day after surgery, typically not more than 2 days in the hospital. So there's very quick mobilization. People are up, they're out of bed, they're walking. People are driving within 2 weeks, and they're exercising and doing pretty much just about anything within 3 weeks of the surgery. I would just end by saying that the keyhole concept is certainly not appropriate for all tumors, but for certainly the majority of brain tumors, intracranial tumors that we remove, it is a very reasonable route and concept. If you want to learn more about keyhole surgery, its application, the different tumor types that we can treat, I recommend you visit our website. Our video library has a whole variety of informative videos on this topic. Thank you.